Infant mental health support is support to the mother or primary caregiver and the baby to enhance that relationship, that all-important primary relationship between mum or important caregiver and baby, where all of the relationships throughout the rest of our life come from. So it's so important to get that right in the beginning.
Infant mental health refers to a whole body of work, a philosophy almost, that puts the baby and the baby's relationship with the caregivers at the centre of its thought. And that differentiates infant mental health from adult and child and adolescent mental health services, where actually they're mental ill health services. What we're trying to do is take a situation where a baby hasn't suffered and prevent the baby from suffering through nobody's fault, but through just parents finding it difficult because of multiple stresses to make an emotional connection with their baby.
There's one thing that it's really come through and loud and clear from all the research, that those first 1,001 days are absolutely critical to brain development. And in order to optimise that, babies need to be in an environment where their parents, their primary carers, are able to attune and really connect with their emotional needs as well as their physical needs.
So when we talk about infant mental health, what we are talking about is the understanding of families as well as healthcare professionals of issues with how an infant interacts with its environment, how an infant develops some of its emotional well-being, some of its psychological well-being.
Sometimes there's deeper roots than we realise to do with childhood and how we perceive ourselves and how we perceive ourselves then as parents.
A mum's such a big thing in a child's life, and not to have one was a real big thing for me. So having Wendy sort of just guiding me and just sort of just being there and saying, well, try this. I tried it and it's worked.
I think the reason that we need something that's specialist is because it's the relationship between the mother and the baby is really complex. And I think that as time's progressed and as we've got more research and we've got better understanding about what the baby needs and about how what the mother's role in that is, I think we need a more targeted approach, and we need people who've got specialist skills in being able to understand and assess that relationship, and then knowing what tools and what interventions to use to help.
And because it is relatively new, it's a specialist area, you need specialists to pick up some of the nuances, to pick up things quite early, and then train and educate the other healthcare professionals and parents and families to understand this better.
So what our specialists do is help parents to attune to what the babies are. There's like that sort of, almost like a rear view mirror. We're just sort of noticing from that outside perspective what the baby's communicating to the parents and helping parents see that as a baby as an individual and to meet that individual's needs. And that does really take that specialist, part of the training is about really learning to interpret baby's signs and signals, and then use that, like be an interpreter to be the baby's voice, to use to help parents really see the baby as that individual.
A specialist team is the same way as you need specialist mental health teams for children and adolescents and for adults. There is a concealed trauma in the families that we worked with, which is unresponsive caregiving, which is parents who cannot respond to their child, and this is all social classes. And the trauma to the child is not having a relationship with their prime caregiver, which is alive, which has those serve and return reciprocal interactions going. And that's a hidden trauma because it's not seen. People have to get to know a family and be trusted before you see these hidden traumas. And actually the research shows that a difficult relationship between the main caregiver and the baby, which doesn't leave bruises, which isn't neglect, can be in a lovely household. That combined with other risks is what has the long-term bad effects on the child's development.
Every contact counts with this group, and you know, I can still remember things that midwives and health visitors said to me when my children were little, and I think people forget how powerful they are when they're health professionals. Everybody needs to be aware of the importance of that relationship and how to spot if things are starting to go wrong.
The attachment issues, I guess, infants who are unwell, they might have a trauma related to that, how that affects their psychological well-being, their feeling of safety, their feeling of emotions, and their attachments with people around them. So I think the first gap is perhaps a lack of understanding within society, within healthcare professionals, that actually this is quite important and this can have quite significant lifelong sort of implications. So I think that is on a strategic level, that is a big gap.
I wouldn't want people to think that all families need really intensive treatment, because that's clearly not the case. But all families do need a helping hand in a different way. And it's about being able to offer a range of services to meet all of their needs where they are, which is generally in the community, and when they need it. And then having those services available that can flex. So if families are struggling for a particular sort of phase, then that intense support can be there. But equally, lighter touch support can be available as well. Fantastic work being done in children's centres across the region.
I think we could look at the services that are currently available, and I think we have to looking at pathways, developing pathways, integrated pathways between partners, so that we all work together to be able to provide the service that's needed for all the families, whatever their level of need, around mental health.
Oh, for me, thank you.
It's been a constant in our life that I can think, well, if I can just get to Tuesday when we see Michael, maybe I can get through. We've come here and I've been at my lowest, and it's been kind of a make or break situation. I felt like the only person in the world who'd ever hated pregnancy. So the idea that there was a service out there for someone like me, I was really surprised and really. Hooray!
One mother said to me, she said, I know what my baby wants now, so I don't mind when people are looking at me and wondering why the baby's crying. She said, because I know what my baby needs. And because of her confidence had increased so much, she then was able to access the groups and go out and socialise and feel far more confident in her parenting and enjoy her parenting. And I think that also has a knock-on effect on the wider family and the relationships between partners and the entire family and other children as well within the unit.
I was working with a mother who was referred by the health visitor and midwife because there was very little contact between her and her baby, absolutely no eye contact, 2.5 months. And I worked with this mother for about a year, seeing her once a week and then cut it down. In this particular family, when I did a follow-up 11 years later, the child had turned down the offer to go to grammar school and had a reading age of 14 and had not had any brushes with social care, had not got into any sort of trouble, and still had a reasonable relationship with her mother. So one could have seen from the early intervention that this couple, where there was no eye contact, the baby seemed to be showing pre-autistic traits, that without intervention their understanding of each other would have just diverged, whereas all I did was bring the understanding back in parallel.
We both had difficult upbringings, and it's allowed us to kind of look at what's been good and what's been not so good in our upbringings, and how we want to kind of use that to bring up Tabitha.
So if I had to put it in a nutshell, I guess what I would be saying is we need more parent-infant psychotherapy work and more of that parent-infant partnership work. What would be helpful in the first instance is to just really bring a lot of the really excellent services that are out there already and bring them together, but think a little bit more about what we offer families. So it isn't just the specialist end, perinatal services like my own here in Dorset. It's really looking at what midwifery, what health services have got to offer, what the GP can offer, and the wider community, and working in partnership, I think, with other agencies that are out there doing some excellent work. It's just really bringing that all together.